Yes, sir.
Okay, then how many of people? Not many have joined. Only three of us have joined. Uh,
They were joined, sir, further.
they'll be joining probably another 2, 3
Well, sir.
minutes for 7. So another 3 minutes are there for.
3 minutes are there for this.
Today we'll complete the opioids.
Okay, sir.
Uh,
Okay, sir.
we are discussing actually, we discussed opioids, basically the classification of opioids, pharmacokinetics, and we were actually discussing the pharmacodynamics.
Yes, sir.
Any questions on the previous discussions? Any doubts? That's what at the end I told that you can clear off all the doubts at the beginning
Yes,
of
sir.
our next lecture.
Yes. Sir, why there's occurrence of pluralities while giving morphine and other opioids?
Pardon?
Why there's occurrence of pluralities, sir, for while giving morphine and other opioids?
Yeah, morphine and other opiates, especially when they are used intrathecally, they produce more pruritus than when they are given systemically. But there are various theories are there. We do not know exactly why the pruritus occurs. One of the things is stimulation of the fifth nerve nucleus.
Trigeminal,
That is
trigeminal.
trigeminal nucleus. That is one of the things that has been postulated. That's why many of these patients will have more pruritus on the face. Of course, it can
Yes,
occur all over the body, especially when it's
face.
intrathecally. But exact, cause is not known. But can be because of direct effect on the mu receptors.
Receptors.
That is why intrathecal morphine does not produce so much of pruritus when compared to
Right.
the
I
other drugs.
okay,
When
sir.
they're given systemically because direct effect on the mu receptors in the brain. So, but can be decreased by pre-medication with 5-vitamin 3 receptor antagonists like
Okay, sir.
ondansetron. Ondansetron is one of the drugs that can be used, which can prevent pruritus and also
Okay,
can be
sir.
used for treatment of pruritus. The other
Okay.
drugs that have been used are pentazocine, 15 milligrams of pentazocine,
Fantastic.
maybe because of the effect on the mu antagonism.
Okay,
They
sir.
may produce some amount of relief. Pentazocine has been used. Butorphanol also has been used. 1 milligram butorphanol has been used to decrease the pruritus. And the other drug, low dose naloxone.
Low resolution.
Low dose naloxone, say 30 to 40 micrograms of naloxone also has been used to treat, pruritus. And many times even probably thinking that it may be because of the histamine release of the opioids. So antihistaminics also have been used, like diphenhydramine, chlorpheniramine maleate, promethazine. So all these drugs have been used to, treat pruritus. That is one of the common side effects,
Side
and
effects.
especially when you use intrathecal fentanyl for labor analgesia.
Yes, sir.
Because intrathecal fentanyl is one of the commonly used opioid for labor analgesia. So along with epidural catheter, you place majority of the times when we go for walking epidurals. So though it's called as walking epidurals, many times we go for a combined spinal epidural. So in that we first inject low dose fentanyl, maybe 15 micrograms, 25 micrograms, and along with sometimes along with bupivacaine heavy 2.5 milligrams. That means 0.5%, half ml of bupivacaine and half ml of fentanyl. That is combined together in the same syringe and then injected intrathecally. And then you place an epidural catheter, and that the first almost the latent phase of pain will be looked after by this intrathecal fentanyl and local anesthetic if you have already also given local anesthetic like bupivacaine along with that. But there are two problems that can occur when you give intrathecal this low dose fentanyl and BPOCane, or even without BPOCane also. One is the pruritus. The mother can have pruritus. So if you have already given ondansetron, so ondansetron you still use before giving opiates, because opiates also will produce nausea,
vomiting,
because directly stimulating the area
tumors,
posterior and CTZ at the in the
receptor.
base of the fourth ventricle. So anyway, you will be giving ondansetron. So once you have already given ondansetron 4 milligrams to 8 milligrams, this pruritus incidence is quite low. But the other problem, when you use intrathecal fentanyl for a laboring woman, is if you are monitoring the fetal heart rate, there can be sudden fetal bradycardia. This you have to anticipate, and you have to tell the obstetrician as well, and to the patient also, because a patient who is literate also will be continuously listening to the fetal heart rate. She knows that if there is sudden bradycardia, she also get alarmed, and especially the obstetrician, because any bradycardia, she may think that the fetus might have gone in for a distress, and may want to take up for cesarean section. So beforehand, only if you have informed the obstetrician also that there is always a chance of fetal bradycardia after giving intrathecal fentanyl. So, and it is a transient phenomenon. It is not a continuous phenomenon. It's only for few minutes the child can have bradycardia, and you know afterwards the heart rate will improve and become normal. And now the question for you is, why fetal bradycardia after intrathecal fentanyl? What is the cause? Intrathecal, and that too low dose. What we will be using is only about 15 to 25 micrograms of fentanyl, not higher than that.
Okay.
What is the explanation that has been given for intrathecal fentanyl in laboring women to produce fetal bradycardia? No, if you have gone through the labor analgesia in detail, so you would have known about this. Do you practice labor analgesia in your institution?
Yes, sir. Yes, sir. Yeah,
Do
practice.
practice. So practicing without theory knowledge is not good. But what you give, mostly you may be giving only epidural.
Yes, sir.
You may not be
Epidural.
going in for a combined spinal epidural, isn't it?
Yes, sir. We are giving you epidural. It's labor
Yeah,
epidural.
yeah. So because you'll be using only epidural, you have not seen this problem of fetal bradycardia. That is, when you give intrathecal opioids, the onset of action is quite quick, especially with fentanyl.
Okay.
Because already we have discussed about fentanyl and morphine, the difference when you use intrathecally or central neuraxial administration. Because morphine being a more hydrophilic, it takes its own time to act. It takes almost nearly 60 to 90 minutes for its peak effect when it is given through the central neuraxial route also. Whereas fentanyl being highly lipophilic, it has got supraspinal effects also. So rapidly it gets into the circulation, and it produces a supraspinal effect. And suddenly what will happen is the mother will have pain relief, very fast pain relief, because intrathecal, it occurs within 5 minutes, not more than 5 minutes. So 2 to 5 minutes, the mother will have analgesia. And the second thing is, till then, because the mother has had higher amount of pain, or the pain and anxiety and other things would have produced quite a bit of circulating catecholamines. There'll be very high amount of adrenaline and noradrenaline which are in circulation. So what has the one of the theories that has been put forward for this is, suddenly the amount of adrenaline will come down, but the amount of noradrenaline will remain like that in the circulation after you produce pain relief. And suddenly there is a imbalance between adrenaline and noradrenaline in the circulation. And the effect of adrenaline on circulation is both alpha and beta, and more predominantly beta 2 effect, which produces relaxation of the uterus, but the effect of noradrenaline is contraction, alpha effect, more of uterine contraction. So this is because of this imbalance between adrenaline and noradrenaline, there is a sudden contraction of the uterus, slightly hypertonicity of the uterus will occur, a sustained contraction. And sudden hypertonicity of the uterus can temporarily may decrease the blood flow to the fetus because of the hypertonicity of the uterus. So this may produce a fetal bradycardia. And because we anticipate this, we know that this can occur, and you know we also know that it is not going to produce any problems for the fetus because immediately the heart rate will improve. So, but this has to be known about and this has to be told also. So that is another very important thing which you should always remember about, other than the pruritus when you're using in during labor anesthesia. Okay, so any other doubts regarding the pharmacodynamics we were discussing about the previous class? Any doubts for any others also, because now the participants have increased and most of the students must be there. Anybody has got any other doubts? So otherwise, if you don't have any doubts, just to I'll ask Gautam and Aarti just to enumerate all the pharmacodynamic effects. Still, gastrointestinal tract we had discussed.
Okay,
So
sir.
just tell about the pharmacodynamics of opiates on CNS, then on the eyes, then respiratory system, then cardiovascular system, and GI tract. Just enumerate
Yes,
and
sir.
their
Eyes it will,
importance.
Analgesia,
CNS.
in
Yeah.
CNS.
in eyes it will cause meiosis due to
No,
acting on
start with CNS.
Analgesia,
analgesia.
analgesic
Yeah,
effects.
very good. So analgesia by acting on the mu receptors, and the other mu antagonists and kappa agonists, they produce analgesia by acting on the kappa receptors. Okay, analgesia is the most important thing. So the what is the other important thing as far as the central nervous system is concerned? Can they be used as anesthetics?
They
Or
cannot be used as sole anesthetics, sir.
can they be used as a sole anesthetics?
No, sir.
No,
No,
sir.
sir. You cannot
Yeah,
use
why they should not be used as sole anesthetics?
they can produce the
Because we
Anesthesia.
had already discussed all
There
this,
is no
just to
anesthetic.
enumerate, just to recap things. I'm just asking few questions. Forget the CNS effects.
There is no anesthetic effect, so
No,
only
what do you mean by
analgesic.
no anesthetic effect means what?
there's no amnesia, sir.
Very good. So they don't produce amnesia and they don't produce
Yes, completely.
unresponsiveness.
Unresponsiveness.
Even
No.
in higher doses, they don't produce. They may produce drowsiness, they may produce sleep, but still the
Yes,
patient
sir.
will be responsive for
Mm.
any stimulation, any deep stimulation, and they don't produce amnesia. So that is the reason they cannot be used as sole
So,
anesthetic.
Sole
They have to be
anesthetics.
combined with benzodiazepines, if at all, if they have to be used as anesthetic agents, high dose opiates with benzodiazepines. So the other important thing is, what is the effect of these opiates on inhalation anesthetic agents?
It will it will support the inhalation anesthetic agents, sir.
What?
It will
Huh.
it reduces the inhalation anesthetic agents.
Requirement, you mean?
Requirement, requirement
requirement,
will be reduced.
requirement.
No,
Requirement
that
will be
means,
reduced.
you should always talk in terms of mark of inhalation anesthetic agents.
Okay, sir.
So by using, opiates preoperatively and intraoperatively, how much of reduction of MAC occurs of these inhalation anesthetic agents? What is the percentage of reduction of MAC value?
25 to 25 to 30% reduction.
No, you are just guessing. So it can go up to 50 to 75% reduction can occur when you are using higher doses of opioids. So the
Okay, sir.
MAC value can reduce by 50 to 75%. So that why you should know about this is that the amount of inhalation anesthetic agents use you can always reduce when you are using opiates, because they do produce decreased in the MAC value, so the decreased requirement will be there, and so one can use a smaller amount, and so can produce better depth. Because I told you, keep telling you that anesthesia means it is always hypnosis and analgesia. So analgesia part will be taken over by the opiates. So the inhalation anesthetic agents need not have to produce both hypnosis and analgesia to produce a deep plane of anesthesia. That way, the MAC value will always decrease. So the another important thing is about PONV as far as central effect is concerned, CNS
Yes,
effect. So already just now discussed, by acting on the
Chemorrhagic acid.
CTZ in the area postrema of the floor of the fourth ventricle, they stimulate the PONV, and quite common. And PONV is more common in ambulatory patient. That is a problem. So that's why you have to be extremely careful in using opiates for ambulatory surgeries, because this is one of the problems. And invariably, majority of the times you may have to use a combined dose of combined drug therapy for this prevention of PONV, like a 5-hydroxytryptamine 3 antagonist along with dexamethasone. That will be an ideal choice to prevent postoperative nausea and vomiting induced by these drugs. The other important central effect is the respiratory depression.
yes,
Already we had discussed about respiratory depression in depth, and by acting on the mu receptors, these mu agonists will produce respiratory depression, and by acting on the kappa receptors, the drugs like pentazocine, butorphanol, nalbuphine, they also produce respiratory depression. And the respiratory depression produced by morphine is delayed. It takes almost about 6 to 8 hours, whether you
68
have
hours.
sympathetically or orally or even intravenously. Whereas the respiratory depression of rapidly acting opioids like highly lipophilic opioids like fentanyl is faster. It can occur within 2 hours. And this you have to keep it in mind when you are using opioids. So monitoring of these patients for respiratory depression is very important. So in the respiratory depression means, which part of the respiration or the minute volume is affected? Is the respiratory rate or the tidal volume?
Respiratory rate, sir.
both.
Yeah, respiratory rate is more affected than the tidal volume initially. Later, both respiratory rate and tidal volume will get affected. The respiratory rate will come down drastically with opiates. That is in contrast to our IV anesthetic agents like propofol or thiopentone sodium, where they affect the tidal volume more than the respiratory rate. Actually, when you give thiopentone or propofol, tidal volume will come down, but respiratory rate will increase in order to meet the minute volume as far as thiopentone, barbiturates, or propofol is concerned. Whereas opiates will produce more of uh, reduction in the rate, respiratory rate, than the tidal volume. So you have to know about this. One of the deadly or more dangerous side effect of the opiates, which we do not want actually. But this is used beneficially in which kind of patients? The respiratory depression produced by opiates, where you want this so that you know this you can use it as a benefit.
Ambulatory.
No, ambulatory patient you cannot
Should
use
not
this.
take
Respiratory depression, it can be dangerous. Where you do not want to use muscle relaxants, because muscle relaxants can produce myopathies.
Thyroid. Thyroid.
Huh?
Hypothyroid.
No, no, no.
neuromuscular junction.
You should always remember that many times in ICU, where these patients are mechanically ventilated, many
Blood
times
retention.
we want the patients to have some amount of respiratory depression so that they don't fight the
Fight the
ventilator.
tube. ventilated.
So in such situations, sometimes if you give higher dose of morphine or fentanyl, so the patients can tolerate the mechanical ventilation. Because, majority of the times when we are mechanically ventilating the patients in ICU, we would like to avoid neuromuscular blocking agents. Because these neuromuscular blocking agents, when you use, so critical care myopathy is a very common. The patients require, even after stopping the muscle relaxants, the muscles will have some amount of myopathy, and these patients will require a long time mechanical ventilation, and weaning gets delayed. So in order to prevent using neuromuscular blocking agents, definitely the opiates, when you give morphine or fentanyl continuously, so the amount of respiratory depression that occurs, you need not have to worry at all. So because anyway, ventilating the patient, that is one of the advantages. When you are ventilating the patient, you need not have to worry about respiratory depression.
That's very depression.
When you are not mechanically ventilating the patient, so, and especially like ambulatory patients, or when you want to extubate the patient on table, then this problem in the postoperative period is always there. So even analgesic doses of opiates can also produce some amount of respiratory depression. And the best drug for reversing the respiratory depression can be naloxone.
Also,
Of course, the respiratory depression produced by immune receptors can also be reversed by giving drugs like pentazocine or even nalbuphine, because they are mu antagonists, isn't it? So some amount of reversal of respiratory depression can be done by using pentazocine, or nalbuphine or butorphanol also can be used, but ideal drug would be to go for naloxone, isn't it? So these are some of the CNS effects already we have discussed in detail, and just to recap things. And eyes, already you said that meiosis and
Edinger is the point.
directly acting on the Edinger-Westphal nucleus. This is the third nerve nucleus. So all opioids will produce meiosis, and meiosis can be a therapeutic, thing to sign also that the opioids are effective, are acting. That is one thing. And when the patient has gone for respiratory depression, when you give naloxone, so this meiosis also will, get corrected. The pupils will start dilating. Once, if you are observing the pupils, and if the pupils are getting dilated, you know that the patient's respiratory depression also will get corrected. So that also is another very important thing. And another important thing also we discussed about respiratory depression is the ventilatory response to carbon dioxide is also affected. Patients will have higher amount of carbon dioxide, still the ventilator response may be very less. So respiratory atosis is very common in these patients on opiates. So that because hypercarbia is very common, and this hypercarbia can also produce increase in vasodilatation of the cerebral vessels, increase in ICP. So you have to be extremely careful using opiates in those patients with traumatic brain injury if you are not ventilating them. If you are ventilating them, there is no problem. There is no problem. The other thing is the meiosis also may come in the way of neurological examination of the patients. So that also
Yes, Jesus.
always remember. And I also said which drug will not produce meiosis among opiates.
Methadone.
Pethidine.
Methadone.
Why pethidine will not produce meiosis?
Does not act on Edinger Westphal.
Pardon?
Does not act on Edinger Westphal
No.
nucleus.
No. The reason also I told you, pethidine. So that's why, it is better to, revise things. That's why I'm asking you. Because pethidine is the only, opiate which also has got the anticholinergic activity.
Uh,
Hope you remember it. That is the reason why pethidine produces mydriasis when compared to the other opiates. All other opiates will produce meiosis, where only pethidine can produce mydriasis. Okay, that's about that. And again, the effect of opiates on the respiratory system. Just to recap,
Blunt cough response to
Yeah, one is
intubation.
upper airway reflexes are uptended, and the cough reflex also is uptended. So this is we are using it as a benefit, especially better tolerance of the endotracheal, isn't it? One is for better tolerance of the endotracheal tube once you use the opiates as a pre-medicant drug. The second thing is the the awake fiber optic intubation. When you want to go for an awake fiber optic intubation, and you do not want the patient to have the cough reflex, so it is always better to go for you know the opiates as a pre-medicant. Plus, the rapid sequence induction and intubation using remifentanil. There is one of the drugs that has been used when there is a contraindication for use of succinylcholine or even non-depolarizing relaxants like rocuronium in patients who are full stomach. So then definitely remifentanil has been used for rapid sequence and intubation also. So, and the other important thing about the histamine release and bronchoconstriction, especially with morphine.
Morphine.
And the other thing already we have discussed about respiratory depression. So these are the respiratory effects. So coming to the cardiovascular effects. So what are the cardiovascular effects of opioids?
Decrease
Decrease
heart
of
rate,
heart rate,
BP.
BP.
Yeah, decrease heart rate, especially the fentanyl. And I also told you about the combination of fentanyl, then midazolam and mecuronium. What is the problem with these three drugs when they are combined? Routinely we'll be using severe bradycardia leading to asystole. These I told you one of the drug interactions. How come you have forgotten the whole thing in just 1 week? I hope you remember that what I had told you about
Yes, sir.
this. This drug interaction, you should always remember. There are incidences of asystole when these three drugs are combined. And invariably you will be combining. Invariably you will be giving fentanyl, midazolam as pre-induction drugs, and invariably you will be using vecuronium many times as the sole muscle relaxant for even intubation. High dose of vecuronium, zero point 0.1 milligram per kg body weight. So this can induce bradycardia. So it is always better to use glycopyrrolate as a pre-medicant drug or keep ready atropine, loaded atropine ready. So if there is bradycardia, you can always use it. And what about on the myocardial contractility? Opiates and myocardial contractility.
It decreases the myocardial contractility, sir.
No, again, things, absolute majority of the opiates, especially the drugs what we use, like whether it can be morphine or whether it can be fentanyl, remifentanil, olfentanil, sufentanil, all these drugs, they do not have any effect on myocardial contractility. Hemodynamically, stability they produce, except the heart rate is decreased.
Heart
And
rate.
many times this can be used as an advantage also, decrease in heart rate, especially when you do a laryngoscopy in intubation. There is no increase in the heart rate. So suppression of the intubation response. So that's how, opiates are always used. Yeah, before doing a laryngoscopy and intubation. And especially in those patients where you want to avoid increase in heart rate, especially in patients with coronary artery disease, in
Coronary artery disease.
pre-eclamptic toxemia patients. So it's very effective giving opiates. So they do not have any effect on the myocardial contractility. Which are the opiates which produce myocardial depression? Which opiates produce myocardial depression? Again, pethidine and
Pethidine.
pentazocine.
Okay.
Pethidine and pentazocine produces myocardial depression. And
And it also
other
the pethidine also will cause tachycardia.
yeah, pethidine and pentazocine both will produce increase in heart rate. They may not produce. That is the reason pethidine may not be an ideal agent to be used in patients with coronary artery disease or even in patients where you do not want there is an increase in heart rate, like in valvular heart diseases, especially the stenotic valvular heart diseases like mitral stenosis or aortic stenosis, where increase in the heart rate can decrease, especially mitral stenosis, decrease the emptying of the left atrium. There can be rapid increase in the left atrial pressure and the back pressure effects can occur. And one more important thing about the opiates on the preload and afterload. What is the effect of opiates on the preload and afterload?
Decrease the preload. Decrease the
Decrease.
preload, sir.
Yeah,
Preload, sir.
decrease of preload and afterload. So that is an advantage, especially in those patients where you want to decrease the preload and afterload, like in patients with myocardial ischemia, uh, and also in patients with poor left ventricular function and in patients with cardiac failure. All these patients, they get benefited by slight decrease in the preload limit. One more thing I was telling you about morphine, because of its histamine release, it can produce peripheral venodilation. So where we use this particular effect of morphine for its venodilatory effects.
Pulmonary edema, sir.
Yeah, very good. So pulmonary
Pulmonary.
edema. So where we want the pulmonary congestion to come down, because pulmonary edema means the main cause will be increase in pulmonary hydrostatic pressure, which overcomes the oncotic pressure, and so fluids get shifted from intravascular compartment from the pulmonary arterioles and
To the
capillaries
extra.
into the lungs, interstitium of the lungs. So that is because of that. So if you can decrease the pulmonary hydrostatic pressure, one of the ways is decreasing the venous pressure. So that's how, all these measures what we take, we elevate the head end of the patient and we give 100% oxygen where pulmonary vasodilatation occurs because of the hyperoxia, pulmonary vasodilatation. We give morphine, which also produces peripheral venodilation. We do give diuretics to decrease the pulmonary congestion. So even nitrates sometimes can be used to produce
Nitrates.
pulmonary venodilation. So all these are, so that is an advantage, isn't it? So that's about the effects of opiates on the CVS. Then the gastrointestinal system.
Decrease peristalsis and increase tone.
Yeah, because the incoordinated muscular activity of the gastric smooth muscle and intestinal smooth muscle will occur. So because of that, there is a gastric stasis is there, isn't it? So
Constipation
you
will
have to be
happen.
careful.
Delay anything.
Where they may produce gastric stasis, and especially in those patients where you expect there is a delayed gastric emptying, like diabetic patients with autonomic neuropathy, polytraumatosis. So all these patients, there can be delayed gastric emptying. So that one thing you should always keep in mind. And the second thing is about the constipation, isn't it? Especially chronic use in cancer patients where they're continuously given opioids and that can produce constipation. So that is can be a real problem for these patients. One more problem is paralytic ileus. It can produce, especially in post-operative ileus. Is a problem when you use opioids. So that is another problem you should always think about, and the effect on the gallbladder.
Gallbladder. Gallbladder contractions.
Tone increases.
Increase
Yeah.
body, so there'll be increase in gallbladder. The patient be having a cholithiasis, and we will precipitating the symptoms of
Yeah.
cholithiasis.
So there will be a sudden increase in the pain for these patients where you want to give a pain relief. Actually, the pain can become more severe. One. Second thing is, suppose if they want to measure the intrabiliary pressures, sometimes the gastroenterologist may want to measure endoscopic measurement of the intrabiliary pressure. So actually, if you give the opiates before, the pressures can increase, and spuriously elevated pressures can be produced by these. And it has been seen that morphine and pethidine can increase the intrabiliary pressures to 300 centimeters of water. Such high pressures can occur. 300 centimeters of water pressure can occur. So that is how you better avoid when they want to use when they want to measure the intrabiliary pressure, or use drugs like scopolamine, which is
Scope.
a anticholinergic, or glycopyrrolate as a pre-medicant, which can inhibit this effect of the opiates on the intrabiliary pressures. So that is another very important thing as far as the GI tract is concerned. So till this we had already discussed. Now coming to the other important pharmacodynamic effect on the genitourinary system. So what is the effect of opiates on on the urinary bladder?
Increase
Increase
tone.
tone. Increase the tone.
Is the tone of the detrusor muscle, or increases the tone in the detrusor muscle?
அப்ப என்னாச்சுன்னா அவன்
Yes.
கன்சல்ட் சைன்
Ask him to mute his.
Okay, sir.
Somebody,
வந்துட்டு அந்த ஃபார்ம் வந்துட்டு சார் கௌஷிக் வரல இதை கௌஷிக் தெரியுமா சைன்
please mute all the other phones.
வாங்க வாங்க சொல்லிட்டு
And,
படுபாய் பையன் என்ன தெரியுமா
Yes, sir.
பண்ணா
Mic switch off பண்ணு. Then switch off your mic. Switch off your mic. Class going on. Switch off your mic. Put it mute.
okay, urinary bladder, actually the detrusor muscle tone decreased. That you should always remember. It will not be increased. The tone is, or the detrusor muscles is increased, but the tone of the sphincter increase. Urinary sphincter tone will be increased. So once the urinary sphincter tone is increased and detrusor muscle is actually the tone is decreased. So what will happen? There will be large collection of urine,
Retention of retention.
and the patient may not be able to void. And this is especially a real problem in male patients, and that to older male patients, especially if they also have some amount of enlarged prostate. So this can produce a lot of problem in the postoperative period because of the urinary retention that can occur. I still remember when one of my friends who also an anesthesiologist who was a professor, and he was in just 40s his age, and he underwent fistula surgery. For that, intrathecal morphine was also used to produce very good post-op analgesia. He did not have any pain in the post-operative period, but he had severe distension of his urinary bladder, and he was not able to void. Because I told you, because detrusor muscle tone is decreased, so the bladder can increase in its dimensions, and it can accommodate more urine, but sphincters are, the tone is increased, so the patient will be unable to void. So he had a lot of problems. He had to be catheterized. He was just in 40s. He did not have any increased size of the prostate. So this you should always remember about when you're using opiates. So post-op retention of urine is a problem as far as the genitourinary system is concerned. So one more pharmacodynamic effect, or you can say the side effect of opiates, which can be, a problem, is the effect on the immune system. What is the effect of opiates on the immune system or cellular immunity?
Reduces.
Very important thing, especially ERAS and all those things, cancer surgeries, and even majority research.
Decreases immunity.
So there is a theory that majority of these opiates may produce or inhibition of the cellular immunity. And because of this decrease in the cellular immunity, there is a possibility of delayed wound healing and increased incidence of infection. And the third problem is cancer recurrence. They actually studied this cancer recurrence in patients with colon malignancies and also in prostate malignancies. when they compared the two groups, where one group where they had used opiates, another group that did not use opiates, there was increased recurrence of malignancy in those patients where opiates were used. So that is one thing. But of course, there are other studies also have not uh, come out with these kind of a conclusion. So there is a controversy regarding whether the cancer recurrence is increased or not increased as far as the opiates when they are used in these patients with the malignancy. But one thing you should always remember about that there is a possibility of depressed cellular activity, and you should be careful in using opiates. And what also has been found when intrathecal morphine was used, many of the patients developed, the herpes labialis.
That is serious.
So activation of the herpes labialis, because all of us we do carry this herpes simplex virus in our body, isn't it?
It is
So varicella virus is always there, which can also produce zoster also and labialis also. Um, so especially the oral, the lip, above the lip, herpes region recurrent. So this has been seen, and that's how they studied cellular immunity. Why many of these patients had a recurrence of this herpes labialis. So this is another very important side effect of opiates you should always remember about. And the other important thing is about the opioid-induced hyperalgesia.
hepatitis.
What do you mean by opioid-induced hyperalgesia? This is one of the side effects of opioids.
Okay.
You should always keep it in your mind when you're using opiates perioperatively.
Patient will have pain when we give opioid induced naloxone. If we give naloxone and if we give fentanyl, patient will have pain, sir.
When you use what has been, you should know about this opioid-induced hyperalgesia can be a short notes for you. So many times when opiates have been used in the perioperative period, either as a pre-medicant or intraoperatively, many of these patients in the postoperative period, they have increased sensitivity for pain. The pain sensitivity has increased. The other patients who have not been given opiates, they may not feel so much of pain, but patients who have been given opiates perioperatively have had more intensity of pain in the postoperative period. And this is called as opioid-induced hyperalgesia. And what is the cause for this opioid-induced hyperalgesia? What is the theory behind? What exact cause is actually not known, but there are theories. What is the theory which has been postulated for opioid-induced hyperalgesia? So anyway, probably you have not heard about opioid-induced hyperalgesia, so you will not also know about the reason. So it's mainly they say that probably NMDA receptor activation.
Activation.
Though we know that NMDA receptor activity will be reduced, but when they are given, it can also produce activation of the NMDA receptors, and this produces increased sensitivity for pain, which is called as opioid-induced hyperalgesia. So, how do we, treat this, or how do we prevent opioid-induced hyperalgesia? How this can be prevented?
Giving ketamine, sir.
Yeah, very good. So, you used your common sense very nicely because,
Yes, sir.
ketamine is an NMDA receptor
Yes,
antagonist.
sir. Antagonist. Yes, sir.
So, definitely, because if you also use very low dose ketamine intraoperatively or preoperatively, just a zero point 0.5 milligram per kg body weight of ketamine, it has been found to decrease the opioid-induced hyperalgesia. One
Hepatitis.
drug is ketamine. Okay, what other drugs we can use?
Magnesium, sir.
Yes, very good. So magnesium also 30 milligram per kg body weight of magnesium as a pre-induction dose can decrease opioid-induced hyperalgesia. Okay, any other drug which has been used to reduce opioid-induced hyperalgesia other than ketamine and magnesium? So buprenorphine also has been used because it is a partial agonist. Buprenorphine, when it has been given 25 micrograms per hour infusion of buprenorphine, when you're using other opiates, has also prevented, and also for treatment also you can use 25 micrograms, low dose, very low dose, just 25 micrograms, not per kg body weight, 25 micrograms per hour has been found to be effective because buprenorphine also has got NMDA receptor antagonist. Only one of the opiates which also have got an NMDA receptor antagonism is buprenorphine. So this you should always remember. The other thing which you should always differentiate between opioid-induced hyperalgesia is opiate tolerance. What is opiate tolerance? This is another problem with opioids. Acute tolerance or tachyphylaxis, which is also called as. So many times when you use opioids in the postoperative period, in the preoperative period when you have used opioids, the requirement of opioids in the postoperative period to get the same effect will increase. The requirement of opioids to get the same effect or the same amount of analgesia, you require to give more or higher doses of opioid. And this is called as opioid tolerance. And this is also called as tachyphylaxis. This you should always remember, opioid tolerance. So this is not the opioid-induced hyperalgesia. They are entirely different. Opioid-induced hyperalgesia is decreased sensitivity of pain. Opioid tolerance is increased requirement of opiates for treating the pain. So they are not same, opioid tolerance and opioid-induced hyperalgesia. So these two other effects also you should always remember. So these are the things about the pharmacodynamics and pharmacokinetics of opiates. So let us discuss about the individual opiates. So individual opiates will discuss usually whatever the opiates that are commonly used. Like codeine, we will discuss briefly, which is again, though as anesthesiologists we are not using, but we do find many of the, oral preparations of codeine is always there. And in Western countries, codeine is routinely used in the postoperative, especially for ambulatory surgeries. Codeine is one of the most common drugs that is used along with paracetamol. So codeine we will discuss. We'll also discuss about morphine. Then we'll discuss fentanyl, which is very commonly we use as an individual agent. And also we will discuss pethidine, which will be kept for you in the exam in your drug tray. And we'll also discuss about buprenorphine, which is again another commonly used drug. And we'll also discuss about agonist antagonists like pentazocin and butorphanol and nalbuphine. And also we'll discuss one of the most commonly used very weak opioid, tramadol and tapentadol. Very commonly used drugs, and invariably many times in the postoperative period, surgeons are very fond of using tramadol. Yes, and oral preparations are also available, and parenteral preparations are also available. And also we'll discuss the antagonist, that is naloxone. So these are some of the individual drugs we'll discuss. Let us discuss about codeine. Now, codeine is a very weak opioid, isn't it? It's a naturally occurring opioid alkali. And what is the specialty about codeine? So how codeine acts? What is the mechanism of action of codeine?
Same like morphines.
No, same like morphine. How can codeine act like morphine? Does it get converted to morphine? So actually, codeine is a prodrug.
Product.
Prodrug. So it gets converted to morphine in the liver.
Morphine.
Yeah, because it undergoes demethylation in liver
Codeine
by,
6-2-pronate.
yeah, demethylation,
Demethylation.
not glucuronidation. Demethylation in liver, the O demethylation occurs, and that produces morphine, and nearly about 10% of codeine will get converted to morphine by demethylation in the liver. And this is done by, cytochrome P450 enzyme, especially one of the isoenzymes, cytochrome P450 isoenzyme, that is CYP2D6. This you should always remember. CYP2D capital 6. This is the isoenzyme which converts and which produces demethylation of codeine and converts 10% of codeine into morphine. That's how it will have only 10% of the activity of morphine.
Yeah.
Because we always compare all the opiates with morphine. Morphine is a standard drug. Like how many times one drug is more potent, like fentanyl is 100 times more potent than morphine. Like codeine is 10% as potent as morphine, only 10%, because 10% of it gets converted to morphine. Why you should know about this CYP2D6 isoenzyme?
In some liver disorders, this enzyme will be impaired, sir. On combination of drugs, this liver enzyme will be impaired.
No, especially in Asians, the CYP2D6 is less in amount. The amount of CYP2D6 isoenzyme of cytochrome P450 is the amount is much less. So they'll be resistant to the effect of most of the Asians, whereas it is normal in Western population. So that's how it is extensively used by the Westerners, because it can produce analgesia, at least 10% analgesia like morphine. So that it's quite effective. But some of the patients, some of the population have excess amount of this 2D6 iso enzyme. So if it is present in excess quantity, what is the problem? More amount of codeine gets converted to
To
morphine.
morphine.
The more amount, especially Ethiopians. In Ethiopians, they have excess amount of this. Ethiopia, the African population. There you have to be extremely careful in using codeine, because they can have all sorts of problems of side effects like morphine. And even in Western population, sometimes you'll be using codeine for analgesia. They use in the post-tonsillectomy children, so that respiratory depression should not occur and good analgesia should be there. And some of these children may have excess amount of these 2D6 isoenzyme, and many of these children have gone for severe respiratory depression. And there are incidences, case reports where they have died because they have been given this codeine and they have not been monitored. And in such children, so that's how, in some of the population, you have to be extremely careful about codeine also. But in Indians, in Asian population, it's not a problem. That's why you must have seen this codeine is more commonly used in cough preparations in India. Some of the cough preparations, like Tosex is one of the brand names. It also has the codeine, but they don't give you just like that by the pharmacist. So you require prescription for this. because it contains codeine, and you don't know in which patient there is this duplication of CYP2D6. It's called as a duplication of 2D6. That means more amount of 2D6 availability, and these patients can develop respiratory depression because excess amount of codeine getting converted to morphine. So this is a few things we should remember about codeine. So the other important drug is morphine. We'll have to discuss in detail about morphine. Morphine is again the drug that is always kept for you in the exam.
Yes, sir.
Morphine is now the gold standard for all opioids is morphine. It is a gold standard. All other opioids are compared with morphine. It is a naturally occurring opioid, the natural alkaloid extracted from papaver somniferum. And the other important thing about morphine is, um, the pharmacokinetics of morphine. What is the, already we have discussed, just because individual drugs we are discussing. What is the pKa of morphine? We had already
Six, sir.
discussed these things. In general, when we discussed about opioids, pKa of morphine. pKa of morphine is 8.
PK 8, from 8.
Yeah, you should always remember, man, last time
Yes, sir.
we discussed so much about this pKa, protein binding and all. So when you're asked a short notes, morphine can come as a short note in the first paper
Yes,
one,
sir.
or it can be asked in the exam also. So pKa of morphine is 8. That's why only about around less than 30% of the drug will be in the unionized form. Majority of the drug in the ionized form. So penetrability, CNS penetrability is much less. That is one thing you should always remember. Second thing is protein binding of morphine is also very less. It is, what is the protein binding of morphine? How much?
10 to 20%.
30%,
Just
35%.
23%. 23%. So if
20.
just think about protein binding, more amount of morphine is available as free form. As protein binding is minimal. So these some of the differences you should always remember about among opioids. Its pKa is 8 and away from the normal plasma pH of 7.4. That's why ionized drug will be in the more in number than the unionized. So it is only about 20-30% will be in the ionized, unionized quantity. Second thing is protein binding is very minimal. More amount of the drug is available in the free form. But the third important difference is the lipophilicity of morphine. What is the lipophilicity of morphine? It is high or very low?
No.
Low, sir.
Yeah, lipophilicity of morphine is very low when compared to the other drugs. It is more hydrophilic than lipophilic. And lipophilicity is very important to penetrate the CNS. That also we have. So what is the inference because of this? Decreased number in unionized molecules, one. Second thing is more hydrophilicity than lipophilicity. What is the effect because of this of morphine?
It does not cross the blood-brain barrier, sir.
No, it has to cross the blood-brain barrier to affect.
Well,
If it
sir.
does not cross, how can it reach mu receptors in the brain? It has to
Well,
reach.
yes, yes.
And you cannot use intrathecally also if it is not crossing the blood-brain barrier. It will cross. Lipophilicity is there, but not much. So
Much.
because of this, what is very important? One thing we have discussed about P half KEO.
Effect concentration.
Isn't delay between the blood concentration and the effective site concentration. There is a lot of delay. What is the delay of this morphine? Onset of action, onset and the peak effect. After inject,
70 minutes.
90 minutes.
it is 60 to 90 minutes.
90
60
minutes.
to 90 minutes is the effective concentration achievement at the mu receptors. Either when you inject in the spinal root, the spinal mu receptors, or when you inject systemically in the CNS. So it takes a long time, isn't it? So you should be very careful. That is the reason I told you that if you want to give morphine for post-op analgesia, at least you should give it 60 minutes before
60 minutes
you
before.
intubate the patient, isn't it? And it is not rapid onset. So what is the other important thing about morphine as far as this delayed onset of action? What problem can occur? Suppose
Intubation.
in the post-operative period you want to give morphine, you're given a dose of morphine, so you do not know that its onset of action is quite delayed or its peak effect is quite delayed because T half KEO is 60 to 90 minutes. What problems can you create?
Respiratory depression.
No, you have given a dose.
Patient should
Okay, sir.
You have given a dose to treat pain
Okay,
in the
sir.
postoperative period of morphine. You give an IV morphine. You know that the peak effect will not occur immediately, take about 60 to 90 minutes. What is the problem here? If you do not know that,
immediate post-operative pain.
pardon?
Immediate post-operative pain will be there, sir.
No, the pain will be there. So what you do if there is a pain and the patient is complaining of pain? Again,
We should give 60 minutes before.
no, that is there already we have discussed. No, if you do not know about this T half KEO of morphine being 60 to 90 minutes, okay, in the post-operative period, you have just given morphine to treat pain, but the patient will continue to have pain, isn't it? So if the patient continues to have pain, what you do? What you do about morphine? If it is not getting relieved by this dose of morphine, what you will give?
Repeat. Repeat dose. Repeat dosage.
Yeah, you will repeat the dose,
Repeat the dosage. Repeat dosage of morphine.
isn't it? If you had known that it is going to act later, 60 to 90 minutes, you are going to wait and you will be using other analgesics to treat pain rather than give one extra dose. So, dose stacking, it is called as dose stacking. Like breath
Dose.
stacking occurs in mechanically ventilated patients, this is called as dose stacking.
Dose.
So, there can be a chance of dose stacking. That means without knowing, you may repeat the dose. You may repeat 2, 3 doses, thinking that, oh, patient is not getting relief, let me give another dose, let me give another dose. Patient appears to be resistant, but actually it is not. That is the reason why you have to know about this pharmacodynamic effect of morphine. So what is the problem if you are repeating the dose unnecessarily?
Respiratory depression.
Yeah, you can produce toxic overshoot. It is
Wash.
called as toxic overshoot you can produce, isn't it? So this is one thing you should always remember for the effect of morphine will be taking a longer time. So this is unusual with morphine when compared to other opiates. So this one thing you should always remember about its T half KO being much prolonged. Okay, and what is the other important thing as far as its metabolism is concerned? How does it get metabolized?
Metabolism in the liver, sir.
The liver by
Morphine 3 and 6 glucuronidase, sir.
it's metabolized by phase 2 reaction. It does
Phase 2
not
reaction.
undergo phase 1 reaction. It directly undergoes phase 2 reaction, that is glucuronidation. It undergoes glucuronidation and the metabolites are morphine 3 and morphine 6 glucuronides. So again, what is the importance of these morphine 3 and morphine 6 glucuronides? How much of morphine gets converted to morphine 3 glucuronide and how much of morphine gets converted to morphine 6 glucuronide?
Morphine. Most of them
Eh,
converted to.
ah,
Morphine 3.
yeah, very good. So
Most of them
90%,
converted.
90 to 95% is getting converted to morphine 3 glucuronide. Only 5 to 10% of it may get converted to morphine 6 glucuronide. Again, what is the effect of morphine 3 glucuronide on the different systems of the body? Is
It
it
has
inert
more
or
analgesic.
it is active metabolite or an inert metabolite? Non-active
Active
metabolites.
M6 is my active metabolic.
Morphine 3-glucuronide, I'm asking. You should always, I hope you are able to listen to my
Yes, sir.
voice
Yes, sir. We can able to
clearly.
listen, sir.
Yeah.
Yes,
you're
sir.
able- Now, is it an active metabolite or inactive metabolite? Morphine 3-glucuronide.
Inactive metabolite, sir.
It's an inactive metabolite.
Metabolite.
Whereas active metabolite is morphine
Morphine 6.
6-glucuronide. Isn't it? So, how much morphine 6-glucuronide is potent when compared to morphine itself? How many times it is more potent? That also I have told you last time.
Fine. 500 times more potent than morphine.
It is 650 times more potent.
600.
650 times more potent than morphine uh, as such. So that is the reason. But when a patient has got normal renal function, effect of morphine 6-glucuronide is hardly will be there. When it is given systemically, morphine 6-glucuronide, that is, suppose if I give morphine intravenous or intramuscular, so it gets converted to morphine 6-glucuronide, which will be excreted through kidneys. It may not have much analgesic effect as such, isn't it? So, but in patients where they have a poor renal function or kidney failure, what is the problem in these patients if you use morphine?
More accumulation of morphine 6 glucuronide, sir.
And the problem of, because I told you it is 650 times more potent as far as analgesia and as far as respiratory depression is also concerned. So there will be chances of more respiratory depression in these patients. In renal failure patients, if you give morphine, that is because of morphine 6-glucuronide. So this you have to keep in mind when using morphine in patients with renal failure. And another thing is oral morphine. The bioavailability of oral morphine is very, very poor because majority of it is metabolized in the liver. That's why oral morphine is also popular, but you have to give more dose oral morphine. And it has been seen that oral morphine may actually, the morphine 6-glucuronide is the one which is acting when you are giving oral morphine because it goes through the liver, first pass metabolism. So it gets converted to morphine 6-glucuronide, and the analgesia may be because of morphine 6-glucuronide. Okay. One more important effect of morphine when compared to other opioids is histamine release. Probably among all the opioids, morphine is the one which releases maximum amount of histamine. So what is this particular thing? Its advantage and disadvantages of histamine release. One advantage already we have discussed because of the histamine.
Decreases the heart rate, sir.
Pardon? The venodilatation. Already we
In the
discussed.
venodilatation.
It helps in pulmonary
Yes, sir,
edema.
venodilatation.
But here you have to be extremely careful in using morphine in which patients because of its histamine release property.
Bronchial asthma patients.
Patients with
COPD.
hyperactive airway diseases.
Hyperactive.
Yeah, airway diseases like it can be bronchial asthma or it can be in COPD patients. You have to be careful because there can be bronchoconstriction can occur and that can be one of the problems of morphine. Okay, coming to the dosages of morphine, that also will be asked about dose of morphine. What is usually the parenteral dose of morphine? Because as anesthesiologist, we'll be using more common the parenterally we use either intravenous or subcutaneous, intramuscular. You can use morphine. So, what is the dose of morphine? Intravenous morphine.
IV dosage is 0.1 mg per kg, sir.
Yeah, very good. So, it is 0.1 milligram per kg body weight. And you know that it will not act immediately. It will take about 60 minutes to peak. So, that is one important thing. What is the intrathecal dose of morphine?
100 to 300 mgs.
Usually, you don't go so high. 50 to 150 microgram. 50 to 150 micrograms is especially the Asian population. I told you it can produce delayed onset of respiratory depression. And when you give intrathecally also morphine, again it takes time. It will not act immediately to produce. It will take about 60 minutes to produce the peak effect. And another important thing about morphine is, why so low dose of morphine intrathecally when compared to IV, you said 100 micrograms per kg body, isn't it? Whereas intrathecally, you say that it is just 100 micrograms, not per kg body weight, just 100 micrograms or 50 to 150 micrograms. So why such a low dose intrathecally of morphine when you use it through the intrathecal route? What kinetic effect of morphine is important here?
Supraspinal effect will be more.
Pardon? Because it is more hydrophilic, does not enter into the systemic circulation. It stays in the mental neurons. It stays in the spinal CSF. It produces maximum concentration in the spinal CSF and on the spinal cord. So it will be effective on the new receptors of the spinal cord. Most of the drug. So that is the reason. Because if you give systemically, it will go through the liver and gets metabolized, isn't it? So that is why when you are giving through the systemic route, like intravenous, you give higher dose, like 100 micrograms per kg body weight. Whereas when you are giving intrathecally, because it is going to stay there, it is not going to come back into the systemic circulation and gets metabolized in the liver. So because it stays there and the requirement is very, very less. So that is why you just give 50 to 150 micrograms of morphine intrathecally. And again, when you give intrathecally, the rostral spread takes a long time to the central mu receptors or supraspinal mu receptors. It takes 6 to 8 hours. So respiratory depression of intrathecal morphine takes 6 to 8 hours. So you have to continue to monitor these patients. Okay, so you don't give ambulatory surgeries intrathecal morphine, though it's the gold standard. So this you should always remember. And another important thing is, because it is not getting into the systemic circulation, it is very safe to be given intrathecal morphine in cesarean sections.
Yes, sir.
Yes, sir.
Because to enter the placental circulation, it has to enter the systemic circulation. Because it won't enter the systemic circulation, it won't enter the placental circulation, it won't get transmitted to the fetus. So that is how morphine is one of the gold standard intrathecal opioid for cesarean section. So you can safely use morphine intrathecally for these mothers. So that you should always remember about. Okay, so epidural dose of morphine.
1 to 2 mg.
Pardon?
1 to 2 mg.
Yeah, you can go up to 2 to 4 milligrams in the epidural route. Morphine, 2 to 4 milligrams, up to 4 milligrams. Usually for Indian population, as you said, 2 milligrams should be more than sufficient. Epidural. Again, it is quite low. Just 2 milligrams, not per kg body weight, total dose of 2 milligrams. It is much less when compared to, for example, in a 70 kg patients, if you are giving IV 0.1 milligram per kg body weight, you go up to 7 milligrams. Whereas epidural, you just give about only 2 milligrams because of its more hydrophilicity than lipophilicity. So, I had told you that you can request your staff members go for intrathecal morphine. So you can request definitely. So you can try epidural morphine. Epidural morphine also you can definitely try, because I usually tell my students, because when I was in JSS, we used to use extensively epidural morphine, and we used what my formula was for this is take 1 vial of 0.25% bupivacaine vial and add 1 ml of morphine. 1 ml of morphine contains 10 milligrams. So in 20 ml, you have added 1 ml of morphine. So that means you have added 10 milligrams of morphine in 20 ml of bupivacaine, 0.25%. So 1 ml of this bupivacaine will contain 0.5 milligrams of morphine. 10 milligrams in 20 ml.
20 ml.
So 1 ml will have 0.5 milligrams of morphine.
0.5
Isn't it? So what I used to advise, because for post-op analgesia, you do not give 0.25% bupivacaine, you go for 0.125% bupivacaine. I always, this thing is that in our hospital, so we would be taking 4 ml of this drug, bupivacaine with morphine. So in 4 ml, how much morphine will be there, Arti?
40.
4 ml of 0.25% bupivacaine, where I have added morphine. How much morphine will be there? Each ml will have 0.5 milligram morphine.
5
In 4 ml, how much morphine?
5.
Yeah, what is the difficulty in this? 1 ml contains 0.5 milligrams. In 4 ml, how much?
2
2 milligrams,
2 milligrams.
isn't it? So I'll take this 4 ml of 0.25% bupivacaine, which contains 2 milligram of morphine, add another 4 ml of saline to this.
Okay.
So what will be the percentage of bupivacaine now?
0.125.
Yeah, now you have got a solution with 0.125%
0.15.
bupivacaine containing 2 milligram morphine, isn't it? So that is the one which I always teach my students. Add 1 ml of morphine to 20 ml of 0.25% bupivacaine. So take 4 ml of this, which contains 2 milligram morphine, make it 8 ml with saline. So it will be 0.125% bupivacaine with 2 milligrams morphine. So this you can use 12th hourly. So bolus doses. So just give 8 ml in the morning, 8 ml in the night. So that is going to be effective analgesia for the patients for almost nearly 12 hours. It's a very easy thing. You don't require a pump also. Otherwise, if you're using fentanyl, you require a continuous pump also in the epidural catheter. And so that way you can always use morphine in the epidural space. So these things you just remember about. Okay, so the other important thing is morphine is extensively used orally for cancer patients.
Yes, sir.
For cancer, pain, probably the opiates are quite effective because they produce the second pain. That is what is I told you already. C fiber.
After C
Most of
fibers.
the cancer pain may be transmitted through C fibers. So that is very important. For neuropathic pain, opiates are contraindicated. You don't give because the opiates can these patients can develop dependency. That is why neuropathic pain, they are not very effective also, and they should not be used. So this important property of opiates you should always remember. Coming to the next opiate, which is most commonly used, is fentanyl. Okay, what about fentanyl? How it is available?
2 ml
2 ml.
ml. How many micrograms in each ml?
and 50
50
ml.
minutes.
50 micrograms per ml, so 100 micrograms per ampule. Is there any other strength that is available? Not strength in ampules,
Uh,
especially for infusion and all in the ICU. 10 ml fentanyl is also available ampules. 10 ml ampules. That you should always know. That means the total fentanyl will be 500 micrograms. So 2 ml fentanyl and 10 ml fentanyl ampules are available, because why I'm telling you, for example, if it has been kept in the exam, 10 ml fentanyl ampule. So then you get confused, isn't it? So you should know that it is also available as 10 ml. Okay, so uh, fentanyl, what is the you know properties of fentanyl? Like what is the pKa of fentanyl?
8.4.
8.4. So how much of the drug will be in the unionized portion?
10%.
Less than 10%.
22%.
Very good. So less than 10% will be in the unionized portion. But what is its T half KU? How much is protein binding? Another thing which I should always ask.
80%.
Yeah, 80 to 90% is high protein binding, and um, most of the drug is in the unionized form. But what is T half KU of? If you just think about these two properties, you may think it must be very, very high T half KU. Must be more than morphine also, isn't it? If you think like this, only these two properties. But what is the T half KU? Well, when you should always give for it to be peaking its effect?
10 to 15 minutes.
Yeah, about 5 to 10 minutes. Because T half KEO is about 5 to 10 minutes. Already we had discussed this. Why T half KEO is, though it's most of the drug is available as unionized, the ionized form, and most of it is protein bound, still T half KEO is just about 10 minutes. What property of fentanyl makes it T half KEO being short when compared to morphine?
Lipophilicity.
Very high lipophilicity. It is 100 times more potent than morphine. Because of its high lipophilicity, it crosses the brain, blood-brain barrier and enters the receptors, central receptors very rapidly. That's how, though its pKa is very high, 8.4, higher than morphine, though its protein binding is much higher than morphine. Morphine is just about 23% protein binding, whereas this is 80 to 90% protein binding. But still T half KO is about 5 to 10 minutes. So why again this you should know is you have to inject fentanyl, because fentanyl every day you are using.
Yes.
So you use fentanyl as a pre-induction drug. Before induction, you always use. But you should also know that you don't give fentanyl after giving propofol,
Yes.
isn't it? If you give fentanyl after giving propofol, by the time you want it to be, peak concentration at the effector site, it will not be there. That is why how much before propofol you have to give, or how much before you do the laryngoscopy and intubation you have to give is at least 5 to 10 minutes. Minimum 5 minutes. Minimum 5 minutes. This you should always remember about. Like lidocaine, its peak effector concentration occurs after 90 seconds. That's how, if you want to use lidocaine, use 90 seconds before to suppress the intubation response. Whereas to suppress the intubation response, if you want to give fentanyl, you give 5 minutes before. So that's how, first you give fentanyl, then you give midazolam, then you give lidocaine, then you give, propofol. Then you can use muscle relaxant. And if you're using non-depolarizing muscle relaxants like vecuronium, you have to wait another 3 minutes. By the time the fentanyl concentration in the brain will be quite high. So when you do a laryngoscopy and intubation, the response will be very much. So that is why you should know about this T half KO of fentanyl is about 5 to 10 minutes. So this always remember. And again, fentanyl is available in many preparations, isn't it? So you have fentanyl transdermal patch also is available, isn't it? So what is the concentrations of these patch that is available patch? What is the minimal concentration and what's the maximum concentration?
Minimum is 180, sir.
Pardon?
Minimum is 180.
No, 12, it starts with 12.5.
Okay.
12.5 micrograms per hour release. That is what? Release, always you look for release. How much release? It is always like that only the patch is written there. How much release will be there per hour release? So 12.5 micrograms per hour, 25 micrograms per hour, then 50, 75, and maximum is 100 micrograms release. So depending on the requirement, adult patients, you may have to go for higher dose. Pediatric patients, you may have to go for a lower dose of these. So that's how they are available in different strengths. So 25 mics per hour. So 12.5, 25, 50, 75, and 100 micrograms. So what is the onset of action of this? How much time it will take to get into the circulation to T half KEO of transdermal? How much before you want to use it? For example, okay,
2 to 3
you want
minutes.
to use it as a for post-op analgesia, the fentanyl patch. How much before you have to apply? Before the surgery?
50.
Is how much you have to know, isn't it? So many times we do use transdermal patch for post-op analgesia for acute pain. Though it is used for chronic pain, it can be used for acute pain also for post-op analgesia in some patients as a part of multimodal analgesia. So you have to apply at least 10 to 12 hours before. T half KEO is 10 to 12 hours for transdermal patch. Okay. Now, the other thing also is transmucosal fentanyl is also available, like lollipops are available, wherein directly they get absorbed into the circulation, they bypass the first pass metabolism. So they can be used as lollipops. So onset of action is quite rapid, about 5 to 10 minutes. Lollipops, transmucosal morphine. Transnasal, not morphine, fentanyl. Transnasal fentanyl is also available. Transnasal fentanyl also available. Again, bypasses the first pass metabolism. And fentanyl also has been used through inhalational route. Inhalational route also is there. So we are not routinely using, but transmucosal route, transnasal route, transdermal route, fentanyl is being used in India also. These three routes are available. We usually use either intravenous fentanyl majority of the times, either for boluses or for continuous infusion. And also we use it for intrathecal or epidural. Especially for labor analgesia, epidural fentanyl is most often used. Very commonly used opioid, and that it will be combined with local anesthetic like 0.1% bupivacaine or 0.0625% bupivacaine or 0.2% ropivacaine. With each ml of local anesthetic containing 2 micrograms of fentanyl is very commonly used in the epidural labor analgesia. Okay, what is the IV dose of fentanyl?
2 mics per
1 to
kg.
2 mics per kg.
1 to 2 mics. You always say 1 to 2 mics. So where you use 2 mics, where you use 1 mic.
2 mics per induction dosage.
No, not induction. Don't think about. We'll come to that next high dose induction, high dose opioid for induction. So what is the dose of fentanyl use? 1 to 2 mics we say. So when do you give 1 microgram? When do you give 2 micrograms? 2 micrograms is given when you want real suppression of the intubation, the sympathetic response to intubation. You slightly go to my higher dose, like in pre-eclamptic mothers or in hypertensive patients. in coronary artery disease patients, in diabetes, in patients with raised intracranial pressures. In all these patients, you go for a higher dose, like 2 micrograms per kg body. In all the other patients, you can just give 1 mic per kg body weight is enough, IV. But you give at least about 5 to 10 minutes before. And, morphine should not be used, already we discussed, for ambulatory patients. How about fentanyl? Can we use fentanyl for ambulatory patients?
No, sir, we cannot able to use
So what is the duration of action of fentanyl? What is the duration of action of morphine?
2 to 4 hours fentanyl.
Yeah, not 2 to 4 hours. It is only 60 minutes to 90 minutes is the duration of action of fentanyl. Maximum duration is 90 minutes, not more. Whereas morphine, it can be, 8 to
24
24
hours.
hours. 8 to 24 hours. So if I give it morphine in ambulatory patient, there is always a problem of respiratory depression when they are discharged and they go home. Whereas fentanyl, if you discharge them after about 2 hours, there is no problem at all. So I can definitely use fentanyl for ambulatory patients. Not much of a problem if you are sending them home after 2 hours, not earlier to 2 hours. How about for the use of fentanyl in pediatrics? Can I use fentanyl in pediatric patients compared to morphine? Morphine should not be used in pediatrics because of they are highly prone for respiratory depression effect of morphine. Morphine being long acting, we don't use. How about fentanyl? Can you use fentanyl?
we can use.
Especially for children, posted for lip surgery and palate surgery. Definitely I can use because, the palate surgery, it will take more time, 2 to 3 hours. By the time the child comes out, the effect of fentanyl will not be there. So the problem of respiratory depression will not be there. Definitely fentanyl can be used. What is the intrathecal dose of fentanyl? Because I told you that it can also be used intrathecal.
10 to 25 mics.
Yeah, usually because what is the potency of intrathecal fentanyl compared to morphine? Because
More potent is
systemically, when
fentanyl.
you use, it is 100 times more potent systemically compared to morphine. So when you use, as a intrathecal route, what is the, just now you are telling,
Fentanyl is
how much more potent than morphine in the intrathecal? It is 4 times more potent. So you give 4 times less dose of fentanyl intrathecally when compared to morphine. Morphine you use 100 micrograms, you use 25 micrograms intrathecally. But because the duration of action of fentanyl, when you use intrathecally, because it is highly lipophilic, it enters into the systemic circulation, its effect is, majority of the effect may be supraspinal, part of it is spinal. So, how does it, already we have discussed, when you combine with local anesthetics and fentanyl, so does it produce prolonged post-op analgesia intrathecally when it is given?
hemodynamic stability.
No, intrathecal fentanyl. Intrathecal morphine, when you give, you use it for post-op analgesia, 24 hours of, 36 hours of analgesia will be there. That is why morphine has been given even in those patients where the thoracic surgeries are being done, like especially cardiac surgeries in pediatrics, give intrathecal morphine. And even in scoliosis surgeries, a single shot intrathecal morphine has been given. Because the analgesia is not segmental. It produces very effective analgesia when you give morphine post-op analgesia, extensive post-op analgesia, long duration of post-op analgesia. That's how, even in joint replacement surgeries, intrathecal morphine. I told you cesarean sections, intrathecal morphine. But when you give intrathecal fentanyl, the duration of action of intrathecal fentanyl is less than the duration of action of local anesthetics because it gets into the circulation because it's highly lipophilic. So its duration of action is 90 minutes to 120 minutes intrathecally, whereas your bupivacaine may act for 3 hours. So because why we use fentanyl intrathecally? Because it is a very good blocker of the C fibers, whereas local anesthetics may not block C fibers conduction of very much. So it produces a better analgesia when you give more intense blockade of local anesthetic can be produced when you use fentanyl along with local anesthetic. That is another reason why you use always fentanyl for epidural. Each ml of epidural local anesthetic should contain 2 micrograms of fentanyl. That's how we could reduce the concentration of epidural local anesthetic to even 0.0625% as an infusion. So that is the advantage of using fentanyl, just 2 mics every ml. Intrathecally also, you can use morphine, fentanyl as a single shot in these laboring women, just 12.5 to 25 micrograms use intrathecal fentanyl. Epidural, every ml containing 2 mics of local anesthetic. So usually go for 4 to 8 ml boluses or infusion depending on whatever the regime you are following, whether it is an intermittent bolus or a continuous infusion or a combination of intermittent bolus with infusion. So that's how you use the fentanyl. Okay, the other drug which we should discuss is any doubts regarding fentanyl?
So
Fentanyl.
that Wooden chest syndrome it will be
Pardon?
occurs on only fentanyl or wooden chest syndrome occurs only in fentanyl, sir.
Yeah, any opiate, all opiates will
Wooden chest.
that is what the woody chest or chest rigidity. Any opiate when you give fast, rapidly, one thing is rapidity with which you inject. Second thing is the high dose when you give. And third thing is the age of the patients, especially the older individuals. So these three are things which that's why when you're using fentanyl, very slowly you have to give. One more thing about fentanyl I did not ask you is high dose fentanyl for induction. Sometimes a high dose opioid induction is done in hemodynamically compromised cardiac patients. For example, if a cardiac patient with poor left ventricular function or in failure has to be taken up for cardiac surgeries, so one can go for high dose fentanyl along with benzodiazepines. Like I told you, midazolam usually you go for 0.15 milligram per kg body weight, which is actually an induction dose of midazolam, 0.15 milligram per kg. But otherwise, normally midazolam we go for 0.01 to 0.05 milligram per kg body weight. But when you want to go for high dose opioid induction, when you want to combine midazolam, you go for 0.1 to 0.15 milligram per kg, high dose of midazolam as well, because it produces hypnosis. And fentanyl, you go up to 25 micrograms per 10 to 25 micrograms per kg body weight of fentanyl. So the problem here is a woody chest problem because high dose you are injecting. So if you are also going in for muscle relaxant, once you are adding, so this woody chest problem or chest wall rigidity is not a problem. So you go for 10 to 25 micrograms per kg body weight, high dose fentanyl for these, hemodynamically compromised cardiac patients. Because cardiac patients, you can still go for this because the majority of these cardiac surgery patients are, ventilated in the postoperative period. So the problem of postoperative, otherwise this can produce quite a bit of postoperative depression, respiratory depression, high dose opioid. But this is not a problem in these patients because anyway you are mechanically ventilating this patient, and analgesia will also continue because high dose fentanyl you would have used. So this is high dose fentanyl. Okay, the other drug which you should always remember, now it is available in Indian market, I told you, is remifentanil. And a lot of theory questions can be asked on remifentanil. Remifentanil. Again, remifentanil, what kind of a drug is remifentanil? The naturally occurring opioid or semi-synthetic or a synthetic?
Synthetic.
Sir.
Yeah, synthetic. It also belongs to phenylpiperidine derivatives, like fentanyl. All these, pethidine, fentanyl, alfentanil, sufentanil, remifentanil, all these are, phenylpiperidine group of synthetic preparation. So that you have to write down. Remifentanil is commonly asked as short notes for you in paper one. So one is that you'll have to highlight it's these things. So one is remifentanil. It is a phenylpiperidine synthetic opioid. So the second important thing is about its pKa. What is the
Seven,
pKa of remifentanil? 7.1. 7.1 is the pKa of remifentanil. And how much of remifentanil will be available as the unionized form?
60 to 70.
Yeah, nearly 70% of remifentanil will be available as, so high number of unionized. And what is the potency of remifentanil or lipophilicity when compared to morphine? How much more potent remifentanil is?
Highly lipid.
No, highly lipophilic, we know how much potent when compared to morphine. Morphine is the standard drug. Always we compare. Like fentanyl is 100 times more potent than morphine. Remifentanil, it is again 100 times more potent than morphine. It is equipotent with fentanyl. Now you have a drug which is available in high quantities unionized portion and highly lipophilic, isn't it? So what can be the T half KO of this drug?
5 to 10 minutes, sir.
It is just 1 minute. No, the difference between fentanyl and this, fentanyl, it is pKa is 8.4. Less number of molecules will be available in unionized form, only less than 10%. Whereas here, unionized form is 70%. Remifentanil. Plus, it is highly lipophilic and it is 100 times more potent than morphine. So T half KEO is rapid. As you inject, the blood concentration as it peaks, the brain concentration also it peaks. So onset of action is very rapid,
1 minute.
very rapid onset. So what is the advantage? Rapid onset.
Rapid sequence induction we can use.
No, rapid onset means you just give before you want its effect,
Yes, sir.
isn't it? Just before, not like 5 minutes or 10 minutes before for fentanyl or 60 to 90 minutes before for morphine. It's not like that. You want the effect immediately. You just give it
Yes.
and it starts acting in just 1 minute, isn't it? So that is the advantage of remifentanil. So rapid onset, rapid onset. What about its metabolism? How it gets metabolized? Does it require liver for its because majority of the opiates require liver for.
Yes, sir.
How about remifentanil? No, it's asked as a short notes. You should know about remifentanil.
Non-esteric
Pardon?
metabolized remifentanilic acid, sir.
No, I'm not asking you the metabolite. How it
Sir.
gets metabolized?
Tissue esters.
Not tissue. It is from in the plasma only.
Plasma
Non-pseudopolyester
esters.
esterases. because
Okay.
it also has got an ester in its structure.
Yes, sir.
So it gets metabolized by ester hydrolysis in the blood. So, rapidly it gets metabolized in the blood. And as you said, the metabolite is remifentanil acid, which is inactive. And because it is rapidly gets metabolized in the blood, what is the duration of action of remifentanil? Like fentanyl, I told you 60 to 90 minutes. Morphine up to 24 to 36 hours. How about remifentanil?
20, 20, 30 minutes, sir.
It is just 3 to 5 minutes.
Okay.
A bolus dose acts only just about 3 minutes to 5 minutes. Onset of action is 1 minute and duration of action is just 3 to 5 minutes. So rapid onset and rapid offset. That is the beauty of remifentanil. Rapid onset and rapid offset. So many times you require such drugs where the duration of its effect you want, you can continue to use it. Once you don't want its effect, you can stop it, and effect will not be there. Like for example, effect on the respiratory depression effect. Want sound anesthesia till it is being used, and after that, you don't want its continuous respiratory depressive effect, isn't it? So that way, remifentanil helps, isn't it? So how much? So because of this property, where all remifentanil can be used? Rapid onset, rapid offset.
Daycare surgeries.
Yeah, very good. So you can use it daycare surgery. You can use it throughout the surgery. Then you stop the drug and send the patient to post-anesthesia care unit, and you can discharge also. There won't be any residual respiratory depressive effect of remifentanil. Okay. Where else? Now, for example, during cath lab, during cardiac procedures, as a MAC, monitored anesthesia care. So I isn't it? You just use it and you stop it, and then patient can be discharged to the ward without any problem because of its rapid onset and rapid offset. This is an advantage. And for example, now you want to give a
Dressing,
anesthesia.
post-operative dressing.
Pardon?
Dressing.
Huh?
Dressing, sir, for dressing, wound dressing.
For dressing like burns dressing, definitely you can use as MAC, monitored anesthesia care. And also when you are trying to give a regional block, so you want the patient cooperation. So you start remifentanil and you can give the blocks. Patient will be very cooperative. For example, a patient has got pain, extensive pain, and you want to position the patient. Patient may not cooperative for regional anesthesia. In such situation, you can give. So because of its rapid onset and rapid offset, so should you be giving it as an intermittent bolus or a continuous infusion? Which is better?
Infusion.
Infusion.
Yeah, you have to use it as an infusion. You can give bolus also, but followed by an infusion. Because if you just give one bolus, it will act for about 3 minutes or 4 minutes, and then again you will have to repeat. So instead of that, you can go for continuous infusion. Stop the infusion. After about 3 or 5 minutes, patient will not have any effect. And for that, you have to know the context sensitive half time of remifentanil. What is the context sensitive half time of remifentanil? What is the context? For example, now I've used remifentanil for about, say, 3 hours. In other patients,
4,
I've
sir.
used remifentanil for 1 hour.
Okay.
What will be the remifentanil contact sensitive half time after 1 hour of infusion or after 3 hours of infusion?
3 hours of infusion, 3 to 4 minutes, sir.
1 hour?
1 hour, 2 minutes.
Whatever the duration of infusion, that is the beauty of remifentanil, is contact sensitive half time is just 3.5 minutes. Even prolonged use, even 10 hours if you stop after 3.5 minutes, the blood concentration will fall by 50% because it does not require liver or any other organ for its metabolism. It is metabolized in the plasma itself and in the tissues itself, isn't it? So that is the advantage of remifentanil. Contact sensitive half time is very, very short. And I told you that remifentanil can also be used for rapid sequence induction, isn't it? So
Yes, sir.
what is the dose of, okay, let us start with what is the, infusion rate and what is the bolus dose you give, what is the infusion dose you will be using, remifentanil. Normal for analgesia. What is the bolus dose and what is the infusion dose? No, that you should know, isn't it?
Yes, sir.
So bolus dose is just about 0.25 to 0.5 micrograms per kg body weight. 0.25 to 0.5 micrograms per kg body weight is the bolus dose. Maximum you can go for up to 1 microgram per kg body weight, bolus. And infusion rate is 0.025 to 0.05 microgram per kg per minute. Infusion is always per kg per minute, isn't it? So you go for 0.025 to 0.05 microgram per kg per minute infusion, up to 0.1 microgram per kg per minute infusion you can go for. So that is how you go for infusion, and even for labor analgesia you can use the same thing, IV. And you don't use remifentanil for central neuraxial blocks. For epidural and intravenous, you don't use remifentanil. Why you don't use remifentanil for intravenous, intrathecal and epidural?
Like highly lipo.
No. No, it's okay. Highly lipophilic, so what? Why can't you use it as an infusion in the epidural space? Because one of the preservatives, it comes always with glycine as a preservative.
Inhibiting
Glycine can be
neurotransmitter.
neurotoxic. Glycine can be,
Inhibiting neurotransmitter, sir.
yeah, it is an inhibitory neurotransmitter. It can be neurotoxic. That is the reason. You may be asked, why remifentanil cannot be used in the epidural space or continuous intrathecal. So this you should always remember. Okay, I told you for rapid sequence induction also, remifentanil can be used. So how much, what is the dose remifentanil for rapid sequence induction, and what is the sequence if you want to use rapid sequence induction of remifentanil? How much is the dose? The dose should be higher than the regular dose or lower than the regular?
Higher than
Higher than the
Yes.
regular dose.
I told you up to 0.1 microgram, up to 1 microgram per kg body weight you go for. Usually for normal, 0.5 to 1 microgram. I told you 0.25 to 0.5, up to 1 microgram bolus. But here you are giving a bolus only, you go for 3 to 5 micrograms bolus. High dose, almost No, 6 times the normal bolus. You give 3 to 5 micrograms bolus. And when do you give? What is the sequence for rapid sequence induction? Without using succinylcholine or rocuronium. You don't have to use succinylcholine or rocuronium when you're using uh, remifentanil for rapid sequence induction.
Before required pressure, giving required.
Usually the sequence is you tell the patient about Cricut pressure and all those things, then pre-oxygenate the patient, and then you give propofol first. Lidocaine you have to give because propofol induced pain you have to relieve. So give lidocaine, then propofol, then remifentanil. And when you give remifentanil, in just 1 minute, the patient will stop breathing because already you would have given propofol. So you should also give glycopyrrolate before, because I told you bradycardia can be quite high with remifentanil also. So glycopyrrolate, lidocaine, then propofol, then remifentanil, 3 to 5 micrograms bolus, and patient will be unresponsive in 1 minute. You just keep asking the patient to repeat 1, 2, 3, 4 like that, and patient will be unresponsive, and you can do a laryngoscopy and rapidly you can intubate and get into the airway, and afterwards you can continue with remifentanil infusion for surgery, analgesia. Okay, regular infusion of say 0.025 to 0.05 micrograms per kg body weight. So that's how you go for remifentanil. So all these things are very important. Remifentanil also can be used for labor analgesia, where I told you that where you don't want to use patient refusal for central uraxial blocks. Remifentanil is the standard now for labor analgesia. You can go for the same continuous infusion with patient-controlled analgesia pump. You can use for patient-controlled analgesia pump. So bolus doses can be about 0.5 microgram per kg boluses. Whenever patient activates, she get the bolus injected. So she should inject at least 2 minutes before or 1 minute before she develops the contraction. Because once the contraction becomes regular, they know when they are going to get the contraction. Just before the contraction, if she injects, so it produces very effective analgesia throughout that contraction phase. Again, she can inject the next dose afterwards. So that's how labor analgesia it can be, or drugs that can be used. Okay, so we still have to discuss. So individual other drugs are also there, like pethidine and buprenorphine is another commonly used drugs. So these two drugs plus the pentazocine, this agonist, then naloxone. Also we have to discuss. I think we do require one more class for that, or at least 1 hour for that. So today it's already time. So what we will do is tomorrow I'm busy in a webinar. I'm taking part in a webinar, so I'll not be able to. So next week we will first 1 hour we will do this. First half an hour maybe. These other two drugs we'll just discuss: pethidine and buprenorphine and other agonist antagonists and naloxone. Then we will go for non-steroidal anti-inflammatory drugs next Friday.
Okay, sir.
Okay. So
Okay,
hope
sir.
you read everything about opioids. So you will never forget in your life. It's you too about the opioids. Okay, any questions, any doubts? Anybody having any doubts? Another 3-4 minutes, we can still, I can answer any doubts if you have. Are you able to see my image clearly, or there is any problem?
We can able to see your image clearly, sir.
Image clearly, because I told you that I'm not in my home in Mysore. I'm in Bangalore in my son's place. I don't know how about the connection and all. So any doubts regarding till now what we discussed, or any other doubts? Any doubt regarding anesthesia, not regarding opiates? Whatever the doubts you can just, you can always ask, and I'm ready to discuss any doubts of any student anytime. You can even ring me up and then ask me anytime. If you have developed a doubt, I am ready to answer. I am always student friendly.
Thank you, sir.
So,
Sir, you told
yeah,
sir, you told us some ceiling effect starting of the opioids.
ceiling effect is not there for mu agonists.
Okay, sir.
Ceiling effect is only for
Used.
partial agonists and
Partial.
agonist antagonists. Like buprenorphine, you have got a ceiling effect because it's a partial agonist, which we'll be discussing in
Understand,
class.
understand.
And again, ceiling effect is there for agonist antagonists like nalbuphine, pentazocine, butorphanol. Ceiling effect is only for those opiates. Strong mu agonists, you don't have ceiling effect. The log dose response curve is straight. Keep increasing the dose, analgesia keeps increasing. No ceiling effect. Good question. Yes. Any other doubt? Okay, then if you have any doubts, you can discuss next. You can even ask any doubts regarding whatever many times you may have a lot of doubts in your day-to-day anesthesia practice. Why it is like that, why is like this and all. So you can definitely ask me. So before we start our regular class, we can definitely discuss all those doubts, and then we can go for our regular discussions. Okay.
Okay.
Because now you're preparing for your exams. Now you have a lot of doubts. Okay, don't hesitate in asking the doubts.
Okay.
These doubts can be doubts for everybody. Don't think that it may be a silly doubt or people will laugh at me if I'm asking about this doubt. No, it is a doubt for others. Others also will get benefited. Never think that it is a silly doubt. No doubt is a silly doubt. Okay. Right then.
Thank
Good
you,
night.
sir.
Yeah, good night.
Thank you.
Thank you, sir. Thank you. The recording disturb.
ரெக்கார்டிங் ஆஃப் பண்ணியா
எப்படி ப்ரோ ஆஃப் பண்றது ரெக்கார்டிங்க?
அங்க சைடில் மோர் ஆப்ஷன்ஸ் போயிட்டு
ஆ,
மோர் ஆப்ஷன்ஸில் வந்து ஸ்டாப் ரெக்கார்டிங்னு ஒன்று இருக்கும் பாரு.
இருங்க.
கீழே நிறைய ஆப்ஷன்ஸ் தெரியுதா உங்க ஃபோட்டோ கீழே?
தெரியுது.
அதில் மோர் இருக்கா?
மோர்
மோரு,
இருக்கா?
செட்டிங்ஸு.
ரெக்கார்டு இருக்கு.
ஸ்டாப் இன்கம் வீடியோவா?
இல்லை
ரெக்கார்ட்
ஸ்டாப் ரெக்கார்டிங்னே இருக்கும் பார். நீ ஃபர்ஸ்ட் ஸ்டார்ட் ரெக்கார்டிங் எப்படி கொடுத்த?
ரெக்கார்டிங்ல போய்
அதுலயே போய் அந்த ஸ்டாப் அதுலயே போ, அதே மாதிரி போ, ஸ்டாப் ரெக்கார்டிங் கொடு. சேவ் இன் கிளவுட் கொடுத்துரு.
இருங்க. அப்படியே போயிடுது.
இல்லைன்னா உன் மொபைல்ல இருந்து அப்படியே அந்த ஸ்க்ரீன் ஒரு ஃபோட்டோ எடுத்து எனக்கு அனுப்பிவிட, நான் காட்டுறேன்.
ஆ. அது அழுத்தினா போயிடுது.
அந்த அந்த ரெக்கார்டுக்கு பக்கத்துல ஒரு ட்ரையாங்கிள் மாதிரி இருக்குல்ல, அதை பிரஸ் பண்ணு.
ஓகே. ஸ்டாப் ரெக்கார்டிங்.
ஸ்டாப்